Hi, my name's Maddie,
I'm Renee.
Kia.
I'm Amber.
and we are doing the effect of electrical stimulation and weight bearing on stroke patients.
All right, going over the clinical scenario and relevance. So firstly, a stroke is when blood supply to a part of the brain is interrupted or when a blood vessel bursts, leading to damages in areas of the brain responsible for motor control. A traumatic brain injury or TBI often results from an external force like a fall or an accident causing damage to the brain. Adults recovering from a stroke or brain injury frequently struggle with regaining upper extremity function due to neural damage, which often results in reduced coordination and muscle impairments. Exploring whether combining electrical stimulation with weight-bearing exercises accelerates and enhances recovery could provide valuable insights for more effective rehabilitation strategies. So our focus clinical question was in adult patients with stroke or brain injury, how does electrical stimulation in combination with weight bearing as compared to electrical stimulation alone promote motor return in the upper extremities?
To break down our PICO question, our patient and client group include adult patients with stroke or brain injury. Our intervention is electrical stimulation in combination with weight bearing. Our comparison is electrical stimulation alone, and our outcome is motor return in upper extremities. These are our search parameters. So the databases and sites we search were Iceberg and Google Scholar. Our search terms included adults, stroke, brain injury, electrical stimulation, weight bearing, motor return and upper extremity. Limits used were peer reviewed, articles dated within the last 5 years, our exclusion criteria, and in total, we found 8 articles.
Inclusion and exclusion criteria. For inclusion criteria, we chose articles dated within the last 10 years. The language spoken was English. The types of studies were empirical studies, qualitative, and quantitative. Peer-reviewed study design was controlled studies measurement, measures of promoting motor return and upper extremity. Specific outcomes, promotion of motor return and upper extremities, utilization of electrical stimulation versus electrical stimulation and weight bearing. And the context was SNFs, outpatient, and inpatient. For the exclusion criteria, the confounding conditions were if you have motor function in the upper extremity, the age, we excluded children. The time since onset excluded anything after 5 years, but we can limit after getting 5 years for results.
This is a breakdown of our level of evidence and the different types of studies that we found. We found 2 different level 1s. We had 1 level 2, 2 level 3s, 2 level 4s, and 1 level 5. With this, our summary of search, we found our 4 best articles. We have a level 3 that it's a before and after design, a level 1 that's a systematic review, a level 1 that's a randomized control design, and then in level 2 that's a single blind randomized control design.
Right now, going over the first best evidence article, as Maddie mentioned, it was a before and after study. So for this study, they tested a treatment program comprising of task-oriented training, TOT, and a repetitive facilitative exercise, RFE, with continuous neuromuscular electrical stimulation, also known as CNMES, for adults who experience paralysis from a stroke. So for this intervention, the OTs performed the RFE under CNMES at first, and then TOT. The intervention lasted for a total of 80 minutes, comprising of RFE under CNMES for around 20 to 60 minutes, and TOT for around 20 to 60 minutes. The amount of time kind of just varied with each patient, and based off of just clinical judgment. The treatments were conducted by 3 trained and skilled OTs that completed an RFE training course and had around 5 to 9 years of clinical experience, including task-oriented training. So the task-oriented RFE with CNMES program promoted motor return for patients with strokes. And by combining RFE with CNMES, it was effective for patients with moderate to severe paralysis after stroke, leading to improvements in their motor control function and daily life use of their paralyzed limb.
The second best evidence article is by Sanchez Cuesta et al. 2023, a systematic level 1 review. In this study, They use repetitive transcranial magnetic stimulation, also known as RTMS. RTMS involves the use of magnetic fields to induce electrical currents in the specific areas of the brain. A coil is placed on the scalp and rapid pulses of magnetic energy are delivered to stimulate neurons in the targeted region, typically the primary motor cortex. Some of the comparison groups involved comparison to sham placebo. Others compared RTMS protocols, including high frequency versus low frequency RTMS, and unilateral versus bilateral applications. Other control interventions included conventional rehab therapies without RTMS. And lastly, audio tape guided relaxation programs were also used as control interventions. In this study, the primary target was the primary motor cortex to improve motor function in the affected limbs of stroke patients, and interventions were applied to assess their effects on upper limb rehabilitation. Evidence that the electrical stimulation, in this case RTMS, promotes motor return for patients with subacute and/or chronic stroke. RTMS is able to enhance arm movement in stroke patients, especially when applied to the ipsi lesional side of the brain.
In our third best evidence article, this objective of the study aimed to investigate the effect of upper extremity proprioceptive training on spasticity and functional motor skills in patients with chronic hemiplegia occurring after a stroke. In this design study, there were 30 chronic hemiplegia patients that were admitted to a research center, and they were diagnosed with chronic hemiplegia developed after a stroke. Patients were divided into two groups. Group number 1 received a conventional physiotherapy program, PTR, for 5 days a week. Group number 2 received PTR for 5 days with additional proprioceptive training program, PTR-PT, for 5 days a week. There were a couple different scales that were used for before and after treatment. So we have the modified Ashworth scale, MOS, the Fugel-Meyer upper extremity motor evaluation scale, FMA, and additional action research arm test, ART, and the motor activity log 28 scale. Those were all applied for a before and after use. The results were that there were no difference in the MOS scores before and after treatment groups. There was statistically significant improvement in both PTR and PT groups for the scales of the FEMA, ARTA, and the MAL. Although the results were obtained in the PTR and the PT groups were more improved, there was a significant result in favor of the PTR-PT only regarding the MAL 28 score. It was determined that adding proprioceptive-based exercises had the greatest effect on the different scales that were used in the evaluation. In conclusion, it was observed that the upper extremity proprioceptive training yielded better results in patients with chronic hemiplegia developed after stroke than conventional therapy in increasing the frequency and quality of movement in the upper extremities. This result showed that proprioceptive training programs should be used or should be added to stroke rehabilitation methods.
The fourth article by Zhang et al. Was mirror therapy combined with contralaterally controlled functional electrical stimulation for upper limb motor function after stroke, a randomized controlled trial. They took 60 patients, it's a single blind randomized controlled design level 2. They took 60 patients, all diagnosed with stroke, focused on training proximal extremities. The study lasted 3 weeks. Patients underwent treatment for 3 to 4 hours a day, 5 days a week. They were split into 4 groups: traditional, which consisted of OT-PT, acupuncture, strengthening exercises, range of motion, speech and stretching and speech, compensatory techniques for ADLs. Another group was the mirror therapy group. So they conducted mirror therapy for an additional 20 minutes along with the traditional. The third group was contralaterally controlled functional electrical stimulation. They also did it for 20 minutes in excess with the traditional. And the last one was only the traditional and nothing else. Patients completed a treatment with testing before intervention to determine baseline and after to gauge results. Zhang and al. Found that mirror therapy paired with another rehabilitative therapy, in this case, contralaterally controlled functional electrical stimulation, far exceeded doing the traditional procedure only.
For our clinical bottom line, the benefits that we came across with the combination of electrical stimulation and weight-bearing activities were improved upper extremity motor function in stroke and brain injury patients, the synergistic effects leading to greater improvements compared to the individual therapies. Some of the strengths that we found was the growing body of evidence supporting the use of electrical stimulation and weight-bearing activities in neurorehabilitation, the potential for significant functional improvements, and versatility of electrical stimulation techniques allowing for targeted interventions. Along with our evidence and limitations of our clinical bottom line, the limited evidence supporting the efficacy of the combination therapy, the heterogeneity in the study designs and the methodologies, limited long-term follow-up data, the lack of standardized protocols for interventions, and the individual variability in response to the treatment. Overall, the combination of electrical stimulation and weight-bearing activities does show promise, but further research is necessary to optimize its application and maximize benefits for patients with neurological impairments.
Right, now going over the implications for practice, education, and future research for all of our best articles. For the first one, some pros were that the task-oriented RFE with CNMES program was feasible for patients regardless of whether their paralysis was moderate or severe, whether it affected their left or right hand, dominant or non-dominant hand, which made the program very widely applicable. The task-oriented RFE program was also safe, well-tolerated, and beneficial for adults with strokes. The improvements were seen in all motor function measures and their patient satisfaction scores. Not necessarily cons, but definitely there needs to be more further research done on this combined RFE and TOT program to examine whether that program enhances the efficacies of each program alone. So for future research, I would definitely recommend seeing the differences of the combined RFE and TOT program, the RFE program and the TOT program alone with electrical stimulation. On top of that, there was a small sample size for this study of only 8 patients, which made it kind of difficult to estimate the outcomes precisely. And the intervention was also performed during their subacute phase where spontaneous recovery could occur. So probably just doing it in a different phase of recovery may also be beneficial for future research.
For the second article by Sanchez Cuesta et al., more research is needed due to lack of assessment of long-term effects of RTMS. So there are questions about the sustainability of improvements. There is also an unclear relationship between brain activity changes and clinical improvements in many studies in the systematic review, indicating that underlying mechanisms are not well understood. There were varied quality of studies with some lacking control groups, randomization, which potentially introduced biases, and then limited participant numbers in some studies affecting the reliability and generalizability of findings.
For the third article for the implications of practice education and the future research, the results suggested that proprioceptive training should be considered as an adjunct therapy. Further research is needed to fully understand the benefits in preventing functional decline and minimizing future problems with patients that have chronic hemiplegia. The upper extremity proprioceptive training did not significantly reduce spasticity in patients with post-stroke chronic hemiplegia. It did improve functional outcomes and quality of movement compared to the conventional treatment alone. Some pros that were observed were significant improvements in the scores of both functional motor assessments. The bilateral training with repeated tasks are performed with both affected and unaffected upper extremities with the aim of achieving a better motor function. Some of the cons from this study were that the devices used can be expensive. The treatment plans, outcomes, and mechanisms have not yet been established. and they could not demonstrate the benefits in terms of spasticity and motor function that they found in patients.
For implications for practice, education, and future research for our fourth article, the results suggest that mirror therapy and CCFES, when used in conjunction with traditional routine rehabilitation, far outweighed prescribing the traditional routine only for improving motor function to the upper extremities. They saw this through the effect of Pupil-Meyer assessment and corticospinal excitability. The researchers found that combining MT with another rehabilitation therapy was far more effective than a single rehabilitation therapy in improving upper extremity function in patients with stroke. So you can lead to a personalized treatment plan, training and education, monitoring and evaluation. I would say, however, that they need more research over a longer, wider scale. And it's pretty cheap to get, be it mirror therapy and CCFS.
And these are our references, and that concludes our presentation. Thank you for your time.